right, good morning. So, this is kind of the obligatory thing. One day we'll have something to put there. Here's our patient presentation. This is a 12-year-old female. No pertinent past medical history. Not currently complaining of any symptoms. She loves texting, playing volleyball, often upset at her parents for no reason. What do you do with this?
Talk to the dad.
Yeah. Seriously though, what do you do with a preteen girl? I need some advice if anybody can help out. Okay, so this is
from TikTok.
Yeah. Yeah, that's the goal. Every day they push the boundary like just a little bit. It's like the boiling pot with the frog. That's how I feel like a parent. So we get an email over the springtime that she's going into junior high. This is the guest of honor, by the way, that chose to sleep in this morning. This is my daughter. This is Kate. And we got an email in the springtime. She's starting junior high, just is about 2 weeks in. And when they transition to junior high, they get to update their vaccines. So we get a message from the school nurse through the junior high that says, we need updated immunization records before she starts junior high. So we make our appointment and go over to the pediatrician, which is a familiar guy. His name's Scott Mumford with Utah Valley Pediatrics. That group is awesome, by the way, if you're looking for a pediatrician. We've been with him since she was born, so 12 years now. And then as a student myself, I actually rotated with him, so I did a rotation in his office. So I've gotten to know their whole staff. They're awesome, very familiar and comfortable relationship. So we take our daughter, Kate, my wife actually took her, to do the immunization. So immunization's given, she's updated, we get the signed off record to hand in. And anything else you would do in that scenario if you're the treating provider?
Check her for scoliosis.
Yeah, right? So he is, the reason I like him is because he is fantastic. I've fallen into the trap a few times myself of having casual, familiar interactions with friends or family or neighbors, and it's kind of contradictory. You think that you would give the best care to somebody that you're familiar with, but sometimes you get a little bit too casual and you don't follow through with what you're actually doing. So he went ahead and did the full well child check, okay, and does his full history and physical exam. Part of that is the Adams forward bend test. If you're familiar with that, it's pretty self-explanatory. They just bend forward, okay? And this is what you're looking for. A healthy individual, it's symmetric, it's rounded, and then if there's any concern for scoliosis, you'll see primarily that they're rotated. So one side will be higher than the other. So he did the forward bend test, our pediatrician with our daughter, and tells us, you know what, I think she's rotated a little bit. You guys should probably, just to be safe, go get an x-ray. So we went and got our x-rays taken, and to my surprise, because I live with this girl every day, okay, and we play together and we do all the things together, and have never noticed, I have never paid attention that there would be anything abnormal or different. But we went and got an x-ray, and I was shocked to see that. What do you notice out of that x-ray? Hopefully it doesn't take a completely trained eye.
Spine's not straight.
Yeah, spine's not straight. Any nuances to that?
Lumbar scoliosis deviating to the left.
Yep. Good.
Yes, joint is totally rotated left side.
Yep. The pelvis is rotated.
Coxa vera.
Uh-huh. Good observation. So yeah, she's got, this was measured, the thoracolumbar junction, this angle was measured at about 39 degrees. And then I think up in the compensatory angle up in the thoracic spine was measured at like 20, I can't remember, 19 or 20. And then she has a really excessive lordotic curve through the lumbar spine. And then the commented also on potentially a partially fused or transitional segment as well. So the anatomy in the spine was quite different. And then as a parent, you start thinking, what does all of that mean? What does that entail, or what does our future look like? So I thought that would be interesting to dive into that, and Dr. Bowden helped and pulled a few articles for me. That was kind of another fun story. I asked Dr. Bowden if she could grab a few articles for me so I can catch up before we go meet with the specialist, because from there, then they want you to meet with a specific pediatric spine specialist. And sure enough, in Dr. Bowden fashion, I got a list of about 45 articles overnight to read, which was awesome. So the term for this is adolescent idiopathic scoliosis. Adolescent meaning that they're younger, typically 10 years and older, and then up until they are skeletally mature. Idiopathic meaning there's not really a rhyme or a reason or a cause that we can identify for that. There's a lot of theories out there, but don't have a specific identifiable cause. Affects females way more often. The lower angle curves, if there's something under about 10 degrees, it's really not considered scoliosis, but those minor curves are not differentiated male and female, but once you get to the higher angle curves, it's way more often in females. 2 to 3% in the general population, and then these higher angle curves, once you start talking over 30 degrees, it's 0.1% prevalence. So this is fairly rare to see. Okay. The treatment options, first and foremost, is just serial monitoring. If this is a first time picking it up, okay, then the easiest thing is give it some time, repeat a picture, and see if it's progressing or how significant or how bad it's going to get. If you're worried about that, this thing's delayed, so I'm scared to click it too many times. Bracing, I think, is the most traditional thing that if you've ever been involved or heard of anything to do with scoliosis, bracing is typically the word that comes up. Physical therapy also plays a role. There's chiropractic interventions, and then ultimately surgery. So, like I said, she has a thoracic and a lumbar curve. Her cob angle is measured about 39 degrees. She's pre-menarche and a riser grade 0. This is how you can measure skeletal maturity. The biggest issue is that you've got the beginnings of an abnormal curve, but they still have all of their growth potential. So that's when you need to be the most concerned. That's where you can see the most rapid progression of these curves. So she was a riser grade 0, which is the end of the scale, up to a 5. And so significant growth potential left, at least in her bones. So we elected for bracing. I think that'll play. This was eye-opening for me. This was her just getting her brace actually put on and learning how to wear it. The process took about 3 hours to get her put into this brace. Once we had the brace, it took about 3 weeks to actually fabricate it. She went for an appointment before that and was measured, and that was another couple hours to get her measurements all done, sent off to the company. They fabricate and create this customized fit brace, and then it took her about 3 hours for them to specifically fine-tune and mold it. This is a material called orthoplast. The therapists are probably familiar with this. You heat it up, it becomes pliable, and it cools down, and then it's in a rigid position again. So they heat it up, mold it, try and fit it to her, mark where they're going to make some changes. They heat it up, mold it again, fit it to her. Took about 3 hours, and was a significant ordeal. And then they have these body wraps, so they can actually see how it's fitting to the contour of the body. Bracing types, this is called a Rigaud-Chenot brace. There's a handful of different types. Traditionally, it used to be a plaster mold and a cast that was just on all of the time. I think we've evolved quite a bit from there, and there's quite a few different options. I think this is probably the most common form used today, is some variation of this molded orthoplast. A few important concepts with bracing. That really the two parameters that you're measuring or that you're watching with this, it's the cob angle and then the growth potential that we talked about. Those are the two factors that will play into how significant or how long or when you're wearing the brace. Those lower riser grade 0s, and then a curve over 20 degrees is when you can just start the bracing. You don't need to worry about watching for any kind of progression. The bare minimum, this was a big argument. The bare minimum is 12 hours a day in the brace, which essentially is just wearing in the evening and sleeping in the brace. versus what they would consider full-time bracing, which is 18 hours or more. And if you're at the bare minimum of 12 hours a day, it is statistically significant, showing great outcomes with that you can at least stabilize the brace. But our conversation with the pediatric specialist was more is better. You can hit the minimum if you'd like, but more is probably better and safer. So she's actually going to try and do 18 hours a day. You plan on doing that until they're skeletally mature. There's a few different ways that they can assess that. The simple way we're doing it currently is with a hand x-ray, which seems a little bit odd, but that's where you can see about 30 growth plates all in one picture. So you can determine what their growth potential and what they have left. The Tanner classification, which is the puberty scale for females, base it off of when they start menarche, how quickly they're growing in height, and then a few other mixed in ways. Those are kind of the standard ways. This was also this interesting fact that I learned, is these kids are supposed to wear this 18 hours a day. So you think of that the opposite way, they only get 6 hours a day where they're not wearing the brace. Okay, so this is a lot of time rigid and stuck in a brace. So the question is, for younger kids, can they compete in sports? Can they go to practice? Can they play games on the weekends? And it's actually encouraged. So it's not that it's just okay to do it, it's actually encouraged to keep them physically active for a few reasons, which I thought was important to note. The surgical techniques, if you get to that point, there's really two schools of thought there. There's the motion sparing or the traditional fusion surgeries. Okay, the two motion sparing options are the tethering, which is kind of shown down here. So there's screws that are placed through the vertebral bodies on the convex surface of the curve, and then there's a tension band. This is not rigid. This is a pliable tension band that's meant to pull across the curve here to not let it keep falling over. And then the posterior dynamic distraction devices. These are jointed rods, so they have the ability to move a little bit, but again, they don't let the curve collapse, and they're meant, as you grow, they encourage the spine to straighten up a little bit. And then there's the traditional fusion, which was really the option presented to us. Is the surgeon that we met with did not feel comfortable with either of those really in any situation, and just wanted to stick with traditional fusion would be the alternative if the curve progresses. I wanted to go back to this. Ben, I was hoping, would comment for us and give us a little bit of history. We got talking when this first came up as well, that he has some experience in this world, and a family member that's been through it as well. Can you tell us a little bit about the surgical outcomes and how that experience has been?
I've had two experiences. My younger brother had surgery for scoliosis, and they did some investigational things with him that didn't actually work. It was a tethering procedure, and eventually he had to have the fusion. My daughter was 11 when we found she had scoliosis. It was early aggressive. It was about a Cobb angle of 65 degrees. And bracing was not an option for us. It was quite a shock when we found it. It was honestly, one day I was mountain biking, riding bikes with her. She was ahead of me, hunched over a bike, and I was like, ooh, there's a problem. So yes, of course, you step back and go, why did I not see this earlier? Why did I not do anything? She had what's called a magic procedure. It was a brand new at the time. This was 10 years ago. Brand new, just had been approved in Utah by our insurance, and I think she was one of the first to have it done. And so it was a tethering procedure when she was 11. They anchored in the lumbar, and then they put kind of these rods going up on both sides that would stabilize. They were able to correct her curve to about 20 degrees and then that tethering was supposed to help manage the growth and help pull her and essentially stabilize her around that 20-degree angle. She would have to go in about, I think it was about every 2 months. There's a mechanism that was on the inside of it that was magnetic, so they put this magnetic thing on the outside and spin it, and it'd spin the gears on the inside and lengthen it to her growth. And so it'd try and match her growth as she went along. She eventually had the fusion when she was 14. So the big, long, nasty fusion. So.
Big, long, nasty fusion, yeah. And lifestyle or implications into
She
life?
can do everything she wants. She does. She's very active. it was tough. That type of surgery at 11. She was on, very active playing sports and competitive sports. She was our daredevil, and it put a little bit of a dent in her confidence, which is unfortunate. I mean, you want them to do everything and so it modified her lifestyle a little bit, not because we protected her. It just happened, and so it was kind of tough. I mean, you get out of the routine of competitive sports and kind of have to find other things. But now she's, we've had a few modifications during high school, like backpacks would always bother her, so we always had to have the William backpack, which she hated. And so, and then, these the upper quadrant is always sore. That's where you have motion, and that's where a lot of muscle activity gets real kind of tough up there. So that above and below the fusion, just like anything, is tough areas. And so, but she can do everything. She loves to show off her scar and loves to show off her hardware. So.
Awesome, cool. So I've been through so far the bracing side of this. It's nice for Ben to share the perspective of the surgical route, but also had a few conversations with people in here as well that there are manual therapies that are meant to be helpful. Has anybody in here had experience treating through the manual therapy world the coronal imbalances and the scoliosis curves?
It's a difficult thing. Everything's different, but there's a lot more advances. I think are getting much better. And working together as a team helps, and really trying to expect outcomes with the family, because there's a lot that goes on. You can't be with them 18 hours a day. But you can see some changes. We've been able to see some 7-degree changes over a year, and that might be good enough to keep some of the more teenagers. We've had 7-year-olds that come in and say, "Hey, I've got a 40-degree cave. Is there any way to get that straight?" And maybe resurrection or something. So those, but usually just keeping the joints moving. You have to look at coupling them at the different angles in thoracic and lumbar, and differently in the cervical. So those things are just to look at. Keep in mind if there's any vertebrae or some other different anatomy, those definitely need to look at, because they can throw off the whole mechanism of biomechanics when it comes to those ankles. So those are good to look at.
Good. Yeah.
So I don't have a ton of experience in this area in therapy. There's a guy here in Lehigh. I think he owns a line physical therapy. He shares some amazing transformations in this stuff. He uses what's called the Schrock method. And maybe some of you are familiar with it, but essentially it's like a 3-dimensional view of the spine and correcting it with corrective exercises. But it'd be cool to hear his perspective, because that's all he does. It's just scoliosis, and like I said, he posts some pretty incredible transformations of these types of cases.
Good. Yeah. That was the what came up in the literature was that method of physical therapy, and kind of, at least in the literature, some mixed results. Ultimately, I think the consensus through the literature is an additive therapy. So therapy alone is difficult to prove that is as beneficial or better than a brace or a surgery, but definitely an additive that was researched for sure. Yeah.
So I think the ones that we see in therapy, minus the ones that are going to a specialist, are the lesser curves. Not they're in the middle. The parents are like, well, we couldn't brace, when it really didn't, know, and then especially if you get to the point where we're talking about an adolescent and they heard the word, maybe we don't need to brace. They're like, well, the doctor said I don't have to brace. Like, what are we doing now? Because nobody wants to wear a brace. You know that. So those are the ones I think that I have more experience with. I have seen some older adults with serious curves, but our goal is, can we work on coupling? Can we keep the spine mobile? That's the only thing we tell the parents. Like, we just want to keep this movable, because when it becomes an immovable spine, then that's when we start to have problems. But if we can, try to work on stretching the short side, right? Strengthening the long side. Can we pull them over? The literature shows that it works. I think we've done a good job at moving it a little bit and helping them be a little bit more upright and maybe getting rid of pain. But again, this is just one of those things, like you're just never going to really fix it. So how can we help them manage it? And then we're still talking about teenagers here. Give them some exercises that they're supposed to do on the day so that they can keep from, Yeah. But you can always just, if you had one of those braces, an older one laying around in the clinic, those would be great because you'd be like, so you could do these or wear this.
Yeah.
And they might, be motivated to do those.
Well, scare tactic. Yeah, I like it. Uh-huh.
One thing to add is we've had some gymnasts at BYU, and they're 45-degree angles, and they're still doing college gymnastics. So I think we can encourage them. Like I said, let's just stay active. Mm-hmm. And they're doing gymnastics 4 or 5 hours a day. Obviously, at that level, they can still do those things.
Yeah.
They can still play sports. They can still. A lot of times they'll come in and they're, like Ben said, they get devastated because it's they think their life's over, and you have to get them through that stage. Now, if they have to have surgery, it's a little bit different, but if we can still encourage them to.
Good.
Yeah.
Good. Okay. To finish up, a couple life lessons learned here through this process for me. Primarily going back to Dr. Mumford at the pediatrician is, turns out the simple and boring things do still matter. Have you guys noticed, has anybody seen an area in your practice or in your specialty? Is there any of these repetitive, seemingly unimportant things that you feel still make a difference for our patients? Because it's very easy to just give the immunization and let the family have what they came for and go on their way. Yeah.
I was, when you were doing this, there was a time in California when I worked with a number of high schools and we did physicals. Mm-hmm. And we were the orthopedic sites of bend forward, touch your toes. If I didn't see this at least 10 times, if I didn't see some sort of a rib hump at least 10 times in every single time I was doing it, then I felt like I wasn't looking hard enough. Mm-hmm. It is very prevalent. Not serious, 15, 60 degrees, but if you watch somebody bend over and you're not seeing do that again and try to go down straight.
Yeah.
Like, I think that's something, at least with this, with scoliosis and girls, I don't think you're looking hard enough. I mean, 8 to 1 is...
Yeah.
Yeah.
Yep. I can think of a dozen examples through my day-to-day in clinic, but I'm interested to hear what the equivalent is in the rest of your practices. Yeah.
So we see a fair number of patients who have been diagnosed with fibromyalgia, and the tendency is to just accept that diagnosis when they come in. They've had it for 20 years. I have fibromyalgia.
Yeah.
But I found that it's very important to ask them, has anyone ever screened for autoimmune diseases? And the majority have not. And we found about 20% that come back with significant markers that are positive for autoimmune conditions.
Yeah.
And the reality is they got lumped into the diagnosis of fibromyalgia, when the reality is they have a completely different process going on that has a completely different treatment for it. And so getting the pre-diagnosis coming in that patients are locked in on sometimes needs to be questioned a little bit. And we find that a lot of the fibromyalgia diagnosis.
Perfect. Great example. Yeah.
His fibromyalgia diagnosis makes me think of a podcast that I did with a researcher at the U. They put a bunch of participants in a study and they sleep deprived them for 2 weeks. So sleep deprivation was defined as less than 4 hours. And every single participant developed fibromyalgia. So just think about like the simple things matter.
Yeah.
Are we asking about sleep?
Yeah.
Like we ask about nutrition. Like that 90% of recovery is just those two things alone. Like we get obsessive about these saunas and all this recovery technique. Literally 90% is just the simple stuff.
Yeah.
Do you get adequate sleep? Are you eating food?
Perfect. Yeah.
Like those are the real simple things.
Basics. I like it. Another one is the right thing to do is not always the easiest thing to do. So this experience reminded me of, again, another famous podcast that I can't get enough of. It's called the Many Minds Podcast. We had a guest, Casey, that does diabetes, and she shared her own personal story. that she was displaying, she now knows, she was displaying all of the classic signs of a type 1 diabetic as like a 10-year-old. And nobody caught it for like 18 months. And she was in and out of clinics and ERs and doctor's visits, and nobody caught it for so long because they were all hesitant to poke a kid and do a blood draw. And so nobody ever actually looked for a long time. And then when she was diagnosed, her blood sugar was about 1100, which is wild. Anyway, yeah, so it's kind of uncomfortable sometimes to order the extra exam or to say, I see that, it seems like this is all kind of matching up, but it just doesn't feel right, or it doesn't seem like we can really close this down as a specific diagnosis, or I'm not confident that this surgery will be the best thing for you. I feel like we need to do X, Y, or Z before we move forward. And people don't like to hear that, and it's uncomfortable, but a lot of times it really is in the patient's best interest. And then lastly, we have to appreciate what we're asking our patients to do. This was also eye-opening to go through the process of the diagnosis and the bracing and all of that. And I would have had no idea that a scoliosis x-ray actually costs about $250. And then the brace itself, that single brace, ends up costing about $3,000. And then they can't promise that's the only one that they need. And that's not typically an insurance benefit that they're going to pay for an orthopedic brace like that. And then the social implications of the brace itself as well. That's been the fight of a life, to get a new 7th grader going into junior high and all of the social parts of life to be able to accept and go forward with that. So it's nice to step back and try and appreciate what it is we're asking of our patients to do and what it is that they're experiencing. Any other comments? Okay, well, I appreciate you guys sharing. Always look forward to hearing what people have to say. So thank you. Oh, go ahead.
So what is your plan? She's bracing now. Are you
Yes, yeah.
doing this surgery to?
Yep, so.
And did you say that the doctor was didn't think that
the tethering, yeah.
worth that?
Yeah.
And you want to just go right to?
Yeah, he said his experience, and then maybe it's just his skill set and his experience and what his skill set is to do the traditional fusion surgery, but he did not have a lot of confidence in these other surgical techniques. But he was fairly confident that we could be successful with the bracing, and he said to plan on about 2 years. So based on her skeletal maturity, she probably had about 2 years left of growing. So 18 hours a day for about the next 2 years.
And then fuse.
And then hopefully not have to do surgery. Yep, the idea of the bracing is to stabilize and not allow any progression. And if they're stable and they reach maturity, then you shouldn't need to correct. Good question. Yeah.
So the brace the goal isn't to reduce the curve at all?
Not really. Nope, it's stability. Yep, not to let it progress any further. Yep. Okay, guys, thank you.